Hello everyone and welcome to the next episode in the series of A to Z of Pathology. Today we're going to talk about terms in pathology beginning with three letters F, G and H. So let's begin. The first one I'm going to talk about is ferruginous bodies. Look at the term, it automatically tells you that there's something to do with iron, right? So what happens is that whenever there is some inorganic dust inhalation, it elicits this fibrotic reaction in the lung, which is called interstitial lung disease. Now, these macrophages in the lung are going to ingest this dust particle, and remember, these macrophages will have ferritin inside them, the stored form of iron. And these particles will then get coated with iron and the protein-rich material. And any accumulation of iron in the form of ferritin is basically aggregates of ferritin that you see as hemosiderin. So you're going to see on H and E brownish structures which are nothing but ferruginous bodies. You can even see some nice giant cells here. Can you make out the macrophages? There's like a nice reaction to it. Now, because they contain hemosiderin or they're coated by hemosiderin, you will have a Prussian blue positive reaction on pearl stain. So if you were to do pearl stain, you'll see these nice structures, and these nice dumbbell shaped structures are actually quite characteristic of asbestos. So when this particle in the ferruginous body is asbestos, you call them asbestos bodies. And remember, they induce a fibrotic reaction. Next, fibrinoid. Now, any medical student will know that the suffix oid means like, right? Epithelioid, amyloid, so fibrinoid, which means definitely something to do with something like fibrin. Now, this is a pattern of necrosis that we usually see in blood vessels, and that means it's got something to do with endothelial cell injury, And what you see is deposition of plasma proteins and fibrin-like material and fibrin-rich material, which sort of looks like a nice granular smudgy around the blood vessels. And the classic examples then would be different types of vasculitis, ranging from small to large, malignant hypertension, which is also called malignant nephrosclerosis, and rejection of transplants, because endothelitis is a very, very classical finding in rejection of transplants. Now, in this blood vessel here, these are the RBCs. That means this is the lumen of the blood vessel. You can see lots of smooth muscle hyperplasia, some inflammation, and in the vessel wall here, you can see the smudgy pink material, which is fibrinoid necrosis. Here's another really nice photo. You can see fibrinoid necrosis, some inflammation, and in the center blood vessel lumen filled with some RBCs and other inflammatory cells. Next, fibrosis. Now look at the term again, fibrous tissue, and osis means increase. So fibrosis is nothing but increased deposition of fibrous connective tissue. Now, as I'm sure everybody recalls, it's a part of normal wound healing and repair. In fact, it is one of the three components of chronic inflammation. The first one of chronic inflammation is mononuclear infiltrate. The second one is that there's going to be tissue destruction. And the third one is that you will see evidence of repair. And that repair is in the form of fibrosis. Now here in this picture, you can see a lot of pink material, right? All of that is fibrosis with some fibroblast nuclei in the middle. This fibrosis will be pathological when it occurs in the bone marrow, which is called myelofibrosis, in the lung in the form of ILD that we just saw, and liver in the form of cirrhosis. And do not forget that as a part of response to invasion of epithelial malignancies within the stroma, you will get desmoplastic stroma. Now, this point has an implication. Whether you're a pathology student or a trainee or a pathologist, whenever you come across cross specimen of a tumor which has been cut, you'll be able to see it looks white, ill-defined margins, and it's quite firm on palpation. Even when you're trying to palpate it in a clinical setting, you'll be able to see that the tumors, the invasive tumors, are firm on palpation. You've got a lot of that to do with fibrosis. And then when you cut it, you'll see a whiteness. Even on radiology, when you get to see a lot of fibrosis, whether it's a part of chronic inflammation or a tumor invasion, that kind of tells you that there is a fibrotic process going on. So it's not just a histopath finding. Actually, I think fibrosis is also something that has a clinical and a radiological implication. Next, look at this photograph. This is liver. You can see cords of hepatocytes, really nice. And they have been separated by bands of fibrosis, pink bands of fibrosis. That means this is a case of cirrhosis of liver. This is a bone marrow biopsy, and this bone marrow biopsy I know because I can see some bone here, bony trabeculae, and I can see some nice megakaryocytes. Can you make out these multi-lobed, and these are some neutrophils. You can tell by the lobes or the multilobation. So I know I'm looking at a bone marrow, but this is not H&E. This is a slide stained with reticulin, which is a silver stain. So it highlights my reticulin collagen fibers, the fibrosis, which is in black. Remember, any silver stain will look black. So this is used in cases of myelofibrosis in order to see whether there is myelofibrosis, and then even in grading. Next, fungating. Now, this is a gross word. Whether it's a clinical term or a gross pathology term, fungating is used to describe any lesion, any tumor that is growing like a fungus and it breaks through the skin. Why does it break through? Once it breaks through the skin, it sort of just outgrows itself a bit too much. It compresses blood supplies, it outruns its blood supply, which then leads to necrosis, ulceration, infection, and a malodorous lesion. So this picture, I'm sure you've seen a lot of clinical settings. Again, pathology residents would be crossing specimens like this quite a lot. You can see this tumor has broken through the skin and it's ulcerated in places. You can see an exudative process going on. So this is a fungating lesion. I would use a similar terminology if I were to describe a similar looking tumor when I cut open a colon or cut open an intestine, whether it's a skin lesion or a soft tissue lesion. Remember, fungating is a gross word. Granuloma. Now, I'm sure everybody knows a lot about granulomas and the different places where we see them, but let's go back. Let's take a throwback to one of the pioneering articles which described granuloma for the first time properly as a compact organized collection. So remember, it's an organization of mature mononuclear phagocytes, whether they are macrophages or activated macrophages called epithelioid cells, which this is very important for you to remember, it may or may not be accompanied by accessory features like necrosis or infiltration of other inflammatory leukocytes. Now, for those of you who want to find out the original article, here is the reference. You can go back to the American Journal of Pathology 1976. I think it's open access. You can read this article, Granulomatous Inflammatory Response. It beautifully describes the basic idea behind how granulomas, both foreign body and immune granulomas, are formed. So the takeaway from this definition is that it's a compact organization of mature mononuclear cells, and they may or may not have accessory features. So here is a foreign body giant cell, which is a multinucleated giant cell formed after the fusion of macrophages. As you can see, the nuclei are sort of not spread out, but more towards the center. Whereas here, this is a Langhans giant cell, where you can see they're towards the periphery, sort of like a garland or a wreath-like or a horseshoe-like appearance. These are formed by the fusion of the activated macrophages. Now, I'm going to give you a classification of granulomas. If you want, you can take it down, especially for the medical students and practicing and trainees in pathology. Now, I've taken a bit of liberty here to give you three headings: infectious, non-infectious, and a very important heading of misnomers, which, as you will know, are not granulomas, and yet we call them granulomas. So the infectious granulomas are, of course, prototypically seen in Mycobacterium, but then you also have fungal and parasitic causes of granulomas. Non-infectious causes include neoplastic, and under neoplastic you'll have lots of examples. For example, Hodgkin lymphoma, seminomas, and adenocarcinomas. Their mucin can elicit a response. Squamous cell carcinoma, their keratin can elicit a response. So neoplastic conditions with granulomas. Then you have non-neoplastic granulomas, which I'm going to further divide into immune-mediated and foreign body. Now, under immune-mediated, I could include causes like sarcoidosis, Ferruginous granulomatosis, Church-Strauss syndrome, temporal arteritis, hypersensitivity pneumonitis, and the list goes on. Foreign body reactions could be seen against anything that the body appears to be feels as foreign, like suture granulomas, tag granulomas, silicone implant have granulomas, and again the list is endless. Now let's come to the most important one among this, because it is a misnomer. I'm going to talk about two conditions here. First is eosinophilic granuloma, and the second one is pyogenic granuloma. Now both of them are called granulomas and yet don't contain them. Eosinophilic granuloma is another name for Langerhans cell histiocytosis, the one that is usually unifocal and in single system. Whereas pyogenic granuloma is a term that is used for a lobulated or a lobular capillary hemangioma. So they are both tumors, but they both do not contain granulomas. They just look like a lot of granular tissue or reddish tissue, hence it's called granuloma. So please remember misnomers: eosinophilic and pyogenic granuloma. Here are a couple of photographs, very classical picture here of central necrosis. And when you get a slide like this where you see central necrosis in a granuloma, for God's sake, don't call it caseating. Caseating term is a purely gross term. You will not see cheese on microscopy. You will see cheese when you see the gross specimen. So here you will call it simply a necrotizing granuloma. Your report should not contain the term caseous. It's just a gross description. Now, around the central necrosis, you can see some pale collection of cells, which is highlighted here. It's the same photograph, and this is the necrosis. And in the periphery, you can see some Langerhans type giant cells. Here again, you can see some dark cells here, the dark nuclei. Those are lymphocytes. And then you can see some pale cells here, which are the epithelioid histiocytes. And then you can see a giant cell. Now you can see there's like the granuloma collection with epithelioid cells looks a little paler than the rest of the lymph node tissue would. And this is AFP stain, so you can see all the cells are pretty much positive, containing all the organisms. So I can safely call this a tuberculous granuloma. Next, this is a classical picture of what we call an asteroid body, which is again a granuloma. You can see a collection here with giant cells. And of course, among other conditions, it's very classically seen in sarcoidosis. This is a very nice picture, and I wanted to include it to show you something, that this part of the slide is normal lymph node tissue. So this is actually a lymph node with metastatic adenocarcinoma. And here you can see the adenocarcinoma, right? And this area is showing you a granuloma. So this is a metastatic adenocarcinoma in lymph node, which has elicited a granulomatous response. So from all these pictures, I chose them specifically to sort of show you the variation in the kind of granulomas we can see and how they don't always mean that something really sinister is going on. Next is granulation tissue. Now, granulation tissue is called so because it has a nice granular, pink, soft, fleshy appearance on gross. And it's made up of three things: fibroblasts, capillaries, which is a sign of angiogenesis, again a sign of repair, and loose edematous ECM because there is leakage from these capillaries. ECM, extracellular matrix. It fills the site of injury, so it's important for scar formation. And it usually contains type 3 collagen, which by the time scar forms is remodeled to type 1 collagen. Now in this photograph, you can see some blue wispy fibers, which is collagen fibers, which is the fibrosis occurring. You can see collections of RBCs here. These are all capillaries. And in the background, you can see white areas. That is all edema. So this is a very classical picture of granulation tissue. So medical students, next time you go to the rounds, especially in surgery, and you're doing wound debridement or some ulcer, you will know it's healing properly when you can see some pink soft granular appearance. That's a sign that scar tissue formation is going to begin. There is healing. Next, hamartoma. Now, hamartoma can be broken down into two terms: hamart, which means fault or defect, and oma, which means tumor. Now, initially thought to be a developmental anomaly, now we think that it should be called a benign neoplasm because of some clonal chromosomal aberrations. Now, hamartoma and choristoma are two terms that everyone normally confuses. So let's see if we can differentiate them. Hamartoma is a disordered mass of normal tissue at normal site. This is a very important point. Why? Because choristoma is normal tissue but at an abnormal site. So choristoma is something like an ectopia or a heterotopia, whereas hamartoma is just normal tissue at normal site, except for the fact that it is highly disordered or disorganized. So it's just grown in a very weird way. That's a hamartoma. And in tumors, in syndromes which have hamartomas, they have been known to be associated with an increased risk of malignancy. The most classical example being the Peutz-Jeghers syndrome. Now look at this photograph here. This is a lung specimen. You can see lung alveoli here. All of this is normal. And here you can see a nicely circumscribed lesion which has a lot of cartilage. You can make out from the blueness of it, right? It's cartilage. So this is a condition called, this is a tumor or a lesion called pulmonary chondroma or a pulmonary hamartoma. This is two pictures in pairs which will basically give you the diagnosis. The first one being of mucocutaneous melanosis or hyperpigmentation, and the second one being a polyp in the intestine which seems to have smooth muscle fibers disorganized to form branches of smooth muscles, resembling what has been called to be a Christmas tree, but in my humble opinion, I'd rather call it broccoli. So this is called a Christmas tree, or as Dr. Diksha calls it, broccoli appearance. Okay, please don't quote me anywhere. It just looks like it, you have to admit. So these are arborizing smooth muscle fibers. Arborizing means tree-like branching, and then you can see the glands around it. So these are Peutz-Jeghers polyps, very classical, and melanosis. Together you'll call it Peutz-Jeghers syndrome if you have multiple of them, and this is involvement of STK11 gene. Now, as I'm sure you will recall, malignancies have been seen in this syndrome classically in pancreas, in breast, in small intestine, in colon. So these are some of the very classical places, even in the FGT, female genital tract. So as I mentioned before, syndromic hamartomas can have increased risk of malignancies. Next, we're going to talk about hyaline. Before I go into what it actually means, let's look at a couple of pictures. So here in this photograph, suppose I were to tell you that this is a picture of lung, and these are alveoli, and around the alveolar side, you can see that they've been sort of outlined by something that is very pink. So hyaline membranes, anything pink, hyaline membranes. In this photograph, let me tell you, these are liver. This is a liver biopsy, and what you see are hepatocytes. And within the hepatocytes, you can see some pink inclusions, right? And here, these are blood vessels. And in the blood vessel walls, you can see that there is some pink deposition which has thickened them, right? So anything that is acellular, pink, or homogeneous in H&E is called hyaline, like I mentioned before. And this tells me that since it's pink, it is likely to be protein rich. It's likely to be proteinaceous. Now this condition here, the alveoli with hyaline membranes, is seen in ARDS, and this is called diffuse alveolar damage. This condition here, these are called Mallory-Denk bodies, and these inclusions are nothing but cytokeratin 8 and 18. They are intermediate filaments damaged, and they collect, and they're called Mallory-Denk or Mallory-Hyaline. The third condition is called hyaline arteriolosclerosis, which is seen in benign hypertension. And you can see damage to blood vessels, sort of leakage of plasma proteins and basement membrane material formation sort of thickens the blood vessel. If you ever get confused between this and fibrinoid necrosis, remember this won't have inflammation. That's necrosis. There's bound to be some inflammatory reaction. Now, I'll put together a couple of photographs for you to show you different ways hyaline can appear both intra and extracellularly. Now here, these are renal tubules. All of these are renal tubules. As I'm sure you recall that you must remember, renal tubules are perform the function of resorption of proteins. So these are called resorption droplets. You can see protein inclusions within the renal tubular cells. These are plasma cells. This photograph is of plasma cells, and within the plasma cells, I'm sure you can make out pink inclusions which have sort of taken over the entire cell. These inclusions are called Russell bodies, and they're classically seen in rhinoscleroma as well as plasma cell myeloma. These are immunoglobulin inclusions. Next, this is liver, where hepatocytes, you can see those things that I had drawn before for you, the pink hyaline, Mallory Denk bodies. Now these are three blood vessels. As I'm sure you can make out, their wall is thickened. As you can make out, there's not much inflammation. It sort of maintains the integrity of the wall just to help you differentiate it from fibrinoid necrosis. This is hyaline arteriolosclerosis. Here, this is a specimen of kidney, a biopsy of kidney, where you can see hyaline deposition in like a nodular form. So this is called nodular glomerulosclerosis, which is very classical of diabetes, also called Kimmelstein-Wilson nodules. And this photograph here is from lung, and again you can see the alveoli have been lined by hyaline membranes that I had drawn before. So this is a case of ARDS. So it's just a plethora of pictures showing hyaline. I hope it helps you recognize next time you come across them. So I hope this video was helpful, and please subscribe, like and share. I hope everyone's keeping safe and keeping well, and I will see you soon. All the very best.